this one's a little bit longer. I'm sorry about that. But you have done a lot of the documentation stuff, and the communication stuff is going to make sense to you. So it's really not all that bad. We're going to look at the various stages of an EMS call. You know, that also is very organized. You know, you can't respond to a call until you get dispatched there, right? You can't go around to the hospital until you pick up the patient. Does that make sense? You probably do, huh? No. We're going to look at using the radio, how to use the radio, how not to use the radio, how to be very careful when you're using the radio. We're going to talk, excuse me, we're going to talk about how you turn over patient care. When you've been treating your patient, you've got to turn them over to the hospital. We're going to talk about how to manage that. We're going to talk about communicating with a whole host of people. Who all do we communicate with? If you're an EMS provider, who are all the people that we communicate with?
Dispatch.
All right, we talk to dispatch. We talk to bystanders. Anybody got one?
No.
Yeah, you do. No, you can think of this. Who all do you communicate with? The patient. You talk to the fire department. May talk to police. You know who you communicate with? Your partner. Physicians, nurses. Family members. ER staff. Yeah, I think y'all covered this about everywhere. So we communicate with a lot of people, and most of those people are going to communicate differently. You're not going to talk to your patient the same way you give report to the ER nurse. So everything's going to be different with communication. You're not going to talk to your partner the same way you talk to your supervisor, are you? Yeah, right. I hope not. So we're going to look at those ways to communicate most effectively. We're going to look at the pre-hospital care report, the PCR, make sure we got all the components of that. We're also going to look briefly at the legal aspects of documentation. Did Henry cover that well with you guys? Yes. The legal part?
Yes,
if you don't,
no,
you don't write it, you didn't do it?
The hospital went into really
Okay.
great detail.
Really? Oh, good. And then we're going to look at patient refusal. We've been through patient refusals in Chapter 4, so we'll just look at that very briefly here. Okay, we have to look at the different communication systems or communication devices that we have. On every ambulance, you should have a radio, a portable radio that you put on your belt or carry. You and your partner, each one should have a radio. We used to have pagers. I don't think anybody carries pagers anymore. Do you know? Sometimes at EMS they may page you with now they text you on your phone. But they'll send you, this is where you're going. They'll be written down. Sometimes it's easier to see it. You'll remember it than them telling you, over the radio. Cell phones, of course, we do use some traditional landlines. So EMS system is uses several different types of communication devices. We have base stations, mobile radios, portable radios. We have repeaters. We have microwave towers, digital radio signals. I think they go into these. Yeah. What's a base station? Yeah, that's going to be your dispatch center. And oftentimes, you'll have a central dispatch center that dispatches police, fire, ambulance. In the big cities, they will have them that dispatch all of that. Sometimes in the smaller cities, they may be compartmentalized, but more commonly, they're bringing those together. So that's going to be a base station. And their communication, their radio equipment is much stronger and is able to broadcast or transmit over a larger area. What is a mobile radio?
The one that's in the trunk.
The one that's in the truck. Yeah, it's mobile. It's able to be driven around. So think of automobile or something. So yeah, it's going to be moving around. So a portable radio is the one you carry with you. And a repeater actually is a tower that picks up the signal from the base station or dispatch and boosts it and retransmits it so it can go further. You see repeaters a lot in mountainous areas, where they have to be heard or transmitted over mountains. So they'll have a repeater high up on the mountain and it picks up the signal and then rebroadcasts it because it can't go through mountains. Microwave transmissions, I never figured out what those are exactly. Well, they must communicate over those. And then, of course, now a lot of us are using digital radio communication. Our cell phones are all digital. This is just an example of how we use the repeater. Like the radio that's actually on the ambulance is not all that strong. It's stronger than your portable radio. So when we broadcast here, we need to hit a repeater so we can get to the base station. Sometimes base station may be able to reach us because they broadcast with a lot more energy than we do. So they'll scatter those repeaters around. One thing that's interesting about repeaters is because it picks up the signal and boosts it and then sends it on, there's a delay in there. So when we're using our radio, we have to understand that there's a delay so that we don't cut ourselves off. We'll talk about that here in just a minute. That happens very frequently. You know, the FCC regulates the use of radios in all communication between public service agencies. They have to have a license, and there are certain rules and regulations, and they do monitor traffic. Just like somebody monitors what goes out over on TV, you know, the FCC will say, you can't say that on TV, and they'll pull you and stuff like that. So, and when you're using any radio, make sure you've got it loud enough that you can hear it, not so loud that it blasts you out. When you're trying to communicate, when you're making a radio transmission, make sure you don't have a lot of background noise going on. I was trying to listen on the radio one time, and this girl was having a serious event down. It was in a gym, and she was down on the floor, and I was way out here. And there was so much background noise, and she's screaming, I need help! This guy's having a seizure. I'm going, what did you say? She's going, blah, 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 blah. So you may have to move someplace quiet so they can hear you. Make sure, here I'm talking about using your mobile radio. Make sure that when you pick up the microphone that you press the little talk button and you wait about a second before you start talking, because you've got that relay system set up. So make sure that there's nobody talking on the radio when you pick it up to talk. And then make sure you press that button. You hold it down for about a second before you start talking. I've just gotten in the habit where I press it, I take a breath, and then I talk. Because what happens if somebody starts pressing and talking at the same time, it doesn't pick up those first few syllables, and it's very easy to cut off what you're trying to say. If you're saying an address that's got, 4 numbers, they're only going to hear 2 numbers. Instead of 2550 Fontaine, they're just going to hear 50 Fontaine. So you've got to make sure that you are understood. Now, when you're using the radio, you don't want to get it up like this because nobody wants to hear what's going on in your nose. So you need to hold it a few inches away from you. Close enough that your voice will carry, but don't get it up in your mouth there. Make sure you're very clear when you're speaking. Don't use a lot of slangs, don't use abbreviations, don't use 10 codes, but enunciate very clearly. I remember years ago, I was working in a brand new city that I'd never been in before, and we were dispatched to a cardiac arrest. And I wasn't familiar with the streets, and I swear the guy was saying Atlanta. And I'd say, did you say Atlanta? And he goes, yes, 3678 Atlanta Avenue. And I'm looking in the book, and there's no Atlanta Avenue. Finally, I said, can you spell that for me? And he said, Volanta, Volanta Avenue. Well, we lost about 10 minutes trying to get that. So make sure that you enunciate. If you use a beginning letter that's difficult, like that was, V and A kind of sounded alike, go ahead and spell it. Say V as in, what do you say?
Violin.
Violin? What's the V word? There's something they always say, like C is Charlie. What's V?
Victor.
What is
V
it?
is Victor.
Victor, that's right, yeah. V is in Victor, Atlanta. Okay, I got that. So, when you're, say, calling another unit, you want to use their unit number first so they pay attention. If I say this, say I'm unit, say, 15, and I'm calling unit 20, if I say this is unit 15, nobody cares, they're not listening. If I say unit 20, and you're unit 20, your ears pick up, you say this is unit 15 or whatever, you need to do blah, 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 blah. So always call them first, say their unit, so that they know who you're calling. So for instance, if you're calling dispatch, you're going to pick up the radio, you're going to say dispatch, this is unit 37A. So dispatch will immediately recognize that you're talking to them. They may, if you call them, they may say stand by. They might be in the middle of something. They may say stand by. So you just wait till they say go ahead. Speak clearly, slowly, keep it brief. only one person can be on your radio system at a time. If there are 15 ambulances out there and everybody wants to talk to dispatch and you're on there talking about who knows what, well, Susie, you didn't give me a call after that last call. Remember, you were supposed to call me. We were going to talk about how we're going to have lunch. And you've got your buddy over here in another unit on another call that has an emergency, can't get through. So state your business and get off. If you want to have a personal conversation, call on your cell phone and talk to them, but don't use the radio for that. Use plain English. Don't use a bunch of codes and stuff, because believe it or not, oftentimes when you leave a district or even go across county lines, certainly across state lines, all those codes change. Usually the 10 codes are the same, but the rest of those numbers, all the way up to 100, they're going to vary from maybe service to service, district to district, certainly county to county. So be careful about using codes that may change as you talk to different people. Be advised. Be advised is very rude, so don't say that on the radio. And I hear people say it among each other. So, well, be advised, blah, 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 blah. That's just rude, so don't say that. You don't need to waste radio time saying please and thank you. That's taken for granted. You're a professional. This is Unit 378. We're en route to, such and such hospital. That's it, or whatever you're required to say. You don't say thank you, please. Would you mind, please, calling the police department and see if they wouldn't mind responding out to such and such? No. We need law enforcement at 3678 Cal Road or whatever it is. And they get it. When you're using numbers, see what works best in your service. If you always say 2078, I like to say 2078. Don't say O. O is a letter. 0 is a number. So say 2078. And that way, it's much easier and it's much more clear. Don't use any profanities or slander anybody on the radio. Now, most of the time we don't do that deliberately, but we do it accidentally. Have you ever done it accidentally? No, good for you. I sat with a partner one time. I think I may have told you guys this when we were in the legal documentation. We were sitting in the truck, and he crossed his legs, and when he did, he pressed his shoe up against the little button on the microphone. So our conversation after that was spread over an entire county. If you all were in Baldwin County that day, you heard what happened on our cardiac arrest, and it was very unpleasant. And my partner said some less than flattering things about the volunteer fire department that was on scene. And we spent a considerable amount of time in the owner's office over that. So I wouldn't say anything in the ambulance itself that I wouldn't want passed on to a bunch of other people. Now, sometimes I know at Mobile Fire, they've got little recording things in there. And they have little video cameras, like if you hit your brakes really fast, it comes on automatically. It records like 6 seconds before you hit the brakes, and then it'll record until things stabilize. So if you happen to hit the brakes and start cussing up, that blank, 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 I can't believe they pulled that in front of me. Somebody's got to hear that, and they're going to call you in. So I would just make a habit of keeping it clean in the ambulance. If you want to talk about personal items with your partner, do it somewhere else. When you're talking on the radio, be objective and impartial. Don't say, God, we're going back to that old lady's house. I've been there 3 times this week. Don't say that. Use we instead of I. I'm going to do this. If it's your unit, your crew, we are en route to such and such. I'm not en route. We're all en route. So say we're en route to whatever. Affirmative and negative is much more definitive than saying yes and no. Because granted, most of us don't say yes and no. We go, yeah. I don't know what that is. And I hear way too much of it. So I know it happened. Yeah. So did you bring your homework? Yeah. What exactly is that? Give assessment information about patient, avoid offering a diagnosis. If you're talking over the radio and you have to pass on information, say, to the dispatcher, just be careful what you say. Because in a lot of areas, the general public can overhear your transmissions.
Here,
Y'all
the
can sit-
newspaper.
The
The newspaper here scans everybody around.
Oh, sure. They love that stuff. Now, some areas, I don't know if Auburn is such, the channels that they're on that the public can't listen in on your channels. Some of them you
No, it's
can't.
Opelika, I think.
You can hear
'Cause I can
Opelika.
pick up Auburn on my handheld.
Oh, really? Well, I know I can just, I used to listen to Mobile Fire Dispatch when I was at home and Tim was at work. You know, I just listened when they called his unit. I'm like, oh, where's he going? So people listen out there. So be very careful what you say. If you consider that everything you say on the radio, everybody in Lee County hears, or whatever county you're from, think about that. Now they say after you finish transmitting, you should say over. You don't really have to say over. You know, if you're done, we're en route to such and such. Dispatch says 10:04, and they usually will give you a timestamp. They'll say 10:47 or whatever. Then you're done. No slang. Make sure if you're using an EMS frequency, it's EMS business. There should be no personal business conducted over the airwaves. If 2 units are transmitting at the same time, they're only going to hear one of you, and you may not realize that they didn't hear you. So when you call in, make sure that they recognize that you've called them. Usually if you say, dispatch is unit 378, they'll come back and they'll say, 378, go ahead. So they will acknowledge you. If they don't acknowledge you, don't just get in there and start, well, you know, we're around to blah, 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 blah. They never got the transmission. It's going to come back and burn you. So make sure that they acknowledge that they've heard you. Because if 2 people are present at the same time, one goes through and the other one doesn't, and it's just kind of random. Dispatch often will repeat back what you've told them to make sure that they understand what you've said. And you should do that also. When they give you directions, say, we need you en route to 3678 Cal Road, you'll say, I got that 3678 Cal Road. So everybody knows what's going on. As I said, they usually will give you a timestamp. And that may be important to you, you write that down, but every communication with dispatch is recorded. And they probably keep those recordings, I don't know, forever. So that timestamp is important. Anytime you leave the ambulance, you take your radio. All right? I already told you guys that, right? I told you about my partner in the plane crash. Yeah. Yeah. Take your radio with you. Make sure the battery's good. Make sure you know how to use it. Okay. When you make a medical radio report, what exactly is that? It's a medical radio report. Yep. And who are we calling? Dispatch?
Hospital.
The ER or-
Yeah, here we're calling ER to tell them where we're going, when we're going to be there, and basically the status of our patient. If you've got a really bad patient, the ER needs to know that so they can plan for your arrival. If they're going to need to call in staff or move a patient out of the trauma bay because you're bringing in somebody really bad, they need to know that. So the worse your patient is, the sooner you need to call.
Lots of times with our fire department, the ambulance will radio head to us to get a status, so that when they get there, they know what they're looking at, so they can get on and get back to get a radio communication back to the ER.
Now you may call in and your patient is stable, but by the time you get there, they're not stable. So if that happens, you want to try to call them back and give them a heads up. Now when you call into the ER on your radio, somebody answers the phone. They may say South Baldwin Hospital or whatever they say. Don't just start giving your radio report. You want to make sure they can take a report, because it could be just some x-ray tech that was walking by and the phone was ringing, somebody screaming, pick up that phone, and they grab the phone. They don't know anything about what you're talking about, and they're certainly not taking notes. So a good policy is when you call in, they pick up the phone, you say, this is unit 378, we have a report to give. Can you take a report? I always ask, can you take a report? Because I've had too many times where I call in and they answer and I start giving them a report, and they say, oh wait, let me get a nurse. Gosh. So now you got to wait. They go get somebody, come back, and you got to start all over. And if you got a lot of stuff going on in your ambulance, you don't have time to give that report twice. So when they come on, I say, this is so-and-so, can you take a report? Can you take a patient report? Yes or no? Yes? Okay, are you ready to write? Yeah. Or they may say, let me get a pen or whatever. So make sure they're ready so you don't have to repeat yourself. And that radio report is very structured. The worse your patient is, probably the more information you're going to give them. But mainly, the first thing they want to know is if they're stable or unstable. Is this somebody I got to worry about, or is this somebody I can just put back here and, let time take its course? So you want to give only the pertinent information, and we'll look at that too. Parts of your medical report, you always tell them who you are. And if you're in an area that uses a tiered system, which means maybe you'll have some trucks that are BLS, which would be, the EMTs, and you have some trucks that are ALS, it would be paramedics, then you need to make sure they know if you're, what your level is, so they'll have an expectation of what you've done. And if you're a BLS truck and you roll in, they'll say, you don't have an IV, why don't you get an IV? It's like, I told you, we're a basic truck. They need to know that. So tell them what your level is and who you are. Because they're going to write that down. Let's say unit 378, when y'all get cold, aren't you? Start to shiver? Yeah. You want to make sure you tell them when you're going to be there. As I said, the worse a patient is, the sooner you need to call. If you've got a patient that is going to need a trauma surgeon or they're pretty bad, as soon as I get on scene and I see that they're really bad, I'm calling the ER and say, I don't have a lot of information, but I have a patient that's, had his arm cut off and, whatever's going on. We've got a really bad MVA here. We've got 2 patients that are going to be critical. I'll call you as soon as I get more information. Then they start jumping around. They're moving patients, they're calling in people, whatever they need to do. So you want to give them that fairly quickly. So you want to give them the estimated time of arrival. Always give them at least 5 minutes. I can't tell you the number of times I've been chewed out because we were so busy. We pull in the hospital bay to offload a patient, and I realize I haven't called report. You know what? I'm sitting right there, and I'm calling report. Oh, we're 5 minutes out, and then we just got there quicker. But don't roll in without having called because they will skin you alive, and it's very painful. You want to give them your patient's age and sex. We say, we're en route with a 56-year-old male. Chief complaint, chest pain. Patient reports chest pain for the last 20 minutes, 7 out of 10 pain. We've given him 3 squirts of nitro and oxygen and an aspirin, and he said his pain is getting better. At this time, we've got him on 15 liters of oxygen. He said his pain is 4 out of 10. He is diaphoretic. He has no past medical history of cardiac of any sort. We will be there in 10 minutes, whatever. So that was pretty quick. That was, about 25 or 30 seconds? They don't want to know what he's allergic to unless he's taken something and he's having an allergic reaction. They don't care about that. They want history of present illness, and if there's anything from the past, I'm out with a patient with chest pain times 30 minutes. He's had 2 prior open heart surgeries. The last one was 1 month ago. Well, that's telling you something different about your patient. Now, mental status, anything that's within normal limits, I'm not going to waste my time and breath. So I would say everything else, vital signs are within normal limits. You don't have to say it because they don't care. But if I've got a patient with a blood pressure of 220 over 120, then I'm going to say, patient's blood pressure is 220 over 120. He says he's got 10 out of 10 headache. So give baseline vital signs only if they're out of range. Otherwise, just say vital signs are within normal limits. If there's anything pertinent in your physical exam, patient has a femur fracture of the right leg and the femur bone is sticking out anteriorly. Okay, they can visualize that. Anything that you've done for the patient. We've placed a tourniquet on the left forearm. It's been on for about 20 minutes. We can control the bleeding. If you've done some care, say the patient had chest pain, you've given him 2 nitroglycerins. He went from 8 out of 10 chest pain to no chest pain. So you say, patient's had 2 nitroglycerins, and now he says he has no more chest pain. And then if you need to talk to medical control or medical direction, you would want to do that. Say, this is Unit 378. We're en route with a chest pain patient. I need to speak to the physician about possibly administering some nitroglycerin. So then they'll go get the physician, you hope. So now, you may have to talk to med control, which at the EMT level, you'll talk to med control a lot. Anytime you give any medication other than oxygen, you have to talk to the physician. If you're giving nitroglycerin, you got to make sure you got all your vital signs, and we'll talk about that later, so you can talk to him and request some medication. If you are you're not sure about how to manage a patient, you're not sure if this is going on or that's going on, and you're not really sure what to do, even if you've done a good assessment and you know what you're doing and you're perplexed, then you may call and say, Doc, I'm not real sure if this is cardiac chest pain. I wanted to give some nitroglycerin. However, it can also be musculoskeletal. And then he'll talk you through it and say, well, does he have this, this, this? Did you ask him about that? And then you may reach a consensus on how to treat. So you may very commonly talk to the med control physician. Now, if he gives you orders to do a treatment on a patient and it goes against what you're allowed to do or what you've learned or what you've been taught, you want to make sure you question him and ask him to repeat it. And if it still is something, like if he said, yeah, go ahead and give him six doses of nitroglycerin. Well, we only give 3 usually in the field. So if he says give 6, then you want to repeat that back. Say, doctor, I'm not real sure. Did you say give him 6 doses of nitroglycerin? Yeah, you give him up to 6 as long as the blood pressure stays above 50. Okay, well, I should tell you then, our protocols say only give 3, so I'll only be able to give 3. How about say, oh, okay, I didn't realize that, or whatever. So make sure you repeat it back. And remember that all of that is recorded. That's a recorded line. So don't say anything inappropriate or disrespectful. If they say something that you don't agree with, to say, okay, thank you, or dispute it. Say, well, normally in this circumstance, we'll give up to 3 nitroglycerin. Would that be okay? And he'll probably say, yeah, that's okay. So don't be rude, don't be inappropriate with them, but you can question them, have them repeat it, and then tell them what your protocols are. Sometimes they're so extremely busy that patients kind of run together for them. And they've got you here, and they've got nurses here, and patients here, so you may have to help them focus a little bit. All right, your verbal report. This is going to be the report you give to the nurse at bedside. Now, who can you turn over patient care to? Nurse, doctor. Hello. Didn't remember this from chapter 4? Who can you turn over patient care to? Somebody equal, training, or higher. So you can turn over care to who? A doctor, a nurse, paramedic, advanced, EMT, okay, equal or higher. Can you turn over patient care to the unit clerk?
No.
To the x-ray tech?
No.
The phlebotomist?
No.
No. All those are no's. Only those people that we talked about can you turn over patient care to. You can turn over patient care to an LPN or RN. So yeah, you got to make sure you know who you can turn over care to. Now, when I'm giving my report at bedside, I always like to know, are you the person that took report? Because if they were the one you talked to on the phone, they already heard your story. So you can kind of pick up and fill in the rest of the report. But if they didn't hear the initial report, they haven't read what was written down, you're starting from ground zero. And I want to know that, because I don't want to have to pick up where I left off and say, well, the patient has what? And you have to back up. So it's just like when you phone in, I always want to know, can you take a report? Yes or no? Same thing. When I come in, are you the person that I gave my radio report to? Yes? Okay then. So you remember what we talked about? Yes. And then you can move from there. Most of the time, you're going to get somebody different. Most probably. And you'll have to start over. But always start by introducing your patient to whoever you're turning care to. Because your patient has bonded with you in that short time you've been together. It's you and that patient. And they think of you now. They've got a medical emergency and you're their best friend. So if best friend abandons you at the ER, that can be very stressful for the patient. Now they're in this room with all this stuff, these people coming and going, you don't know who's what. So here you need to, for your patient's well-being, you need to introduce them to the nurse or whoever you turn over patient care and say, this is Jody. She's worked here forever. You'll be in really good hands. She'll take really good care of you, or whatever it is. Hopefully know them. You probably will. But introduce them by name. You've probably spent some time learning what the patient wants to be called. They do not want to be called honey or sweetie. I'll tell you that for Tim Curry. He calls all the women honey or sweetie. It makes him crazy. So don't do that. It's very disrespectful. But you may ask them, what would you like for me to call you? Like I contacted the lady over at Auburn. We emailed. And the first thing she wrote me back, what's her name?
Miss Childress?
Yeah, what's her first name?
Beverly?
Beverly. Yeah, the first thing she wrote me back, she said, oh, please call me Beverly. Okay, I'm going to call her Beverly. So find out what your patient wants to be called. If I'm your patient and you call me sweetie, you're probably going to have a black eye. And then I'm going to write really bad things to your supervisor. So be polite that way. And give them a more complete, a more detailed report at bedside. When we were coming in, I just said, vital signs are within normal limits. this is what's going on with the patient, you know, this is the bad stuff, this is what we've done. Now when we get there, you want to give them their medications. You know, the patient has a history of blah, 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 and they take this and this and this and this, and, you know, the patient's daughter says that, you know, the patient's been kind of disoriented the last few days or whatever. So give them a whole, round it out, paint that picture for them, just like you're going to be doing when you write your documentation. So because that becomes part of their official, permanent, legal record. So you give them all that information. If they screw it up and they don't treat the patient right, that's on them. But you're required to give the information. I worked with a guy, I wasn't on this particular call, but he went and at bedside he gave a report and he told the nurse at bedside that the patient was allergic to whatever it was. And then he documented it in his report, you know, bedside report, notified the nurse that patient was allergic to blank, gave full report including vital signs, blah, 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 and then wrote the nurse's name. Well, the patient was somehow given whatever that was that they were allergic to. She had a really bad reaction to it, and then she ultimately sued the hospital and sued the ambulance. Well, it started off with us. Well, he could document, I told Nurse Nancy at bedside that patient was allergic to blah, 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 blah. So you want to document something like that. Consequently, the shift moved from us to the hospital. The hospital screwed that one up. So make sure you give a good report and then you document what you told them at bedside. Okay, your report, chief complaint, history of present illness. This is all stuff that you've gotten from your patient. Any assessment findings, pertinent negatives. This is the first time we have seen this word, pertinent negatives. And I want you to commit it to memory because it's so important. Students struggle with this. If you think of pertinent negative as, you know what a negative is? Like if you go in and have a blood test and it's negative, that means you don't have it, right? So if it's something negative, that's something that wasn't found. But is it pertinent that it wasn't found? Just like I want your pertinent past medical history, not stuff that doesn't matter. So a pertinent negative might be patients that are having a heart attack, very frequently they also have respiratory distress. Those kind of go hand in hand. Not always, but if a person is having a heart attack and they've got chest pain, probably half the time or more they're also having a respiratory distress. So if I'm assessing the patient and I say, well, you have any trouble breathing or anything? And they say no. Is that important?
Yes.
Yeah, that's an important negative. That's a pertinent negative. It's pertinent that I did not find that. If you have a patient that is having an allergic reaction to something and they don't have hives anywhere, would that be a pertinent negative? Sure. That would be important that they don't have that. That also lets the reader know, the lawyers that is, that you checked for it and you didn't find it. So if you had a patient with chest pain and you didn't assess for respiratory distress, you've not done your job. But if you assess for it and you don't find it, then that's a pertinent negative and you're going to make sure you document that. Patient has chest pain 6 out of 10 but denies shortness of breath. That is a pertinent negative. So you will see questions either on tests here or on National Registry where it may ask you, of these, which is the pertinent negative? You have to think about that. In order to recognize what the pertinent negative is, you have to know what you should have found. So you have to be very familiar with those signs and symptoms of every single disease or disorder. Okay, interpersonal communication. What is this?
Communication with other people.
Yeah, this is usually going to be people that are closer to you, kind of. All right, as we talked about all the different people that we communicate with, we've talked about on scene, other providers, other units, your partner, bystanders. It's important that you always are very respectful with these people. These are people that you will be working with. If you are rude and short and disrespectful to the volunteer firemen, guess what's going to happen next time?
They'll be rude to you.
Yeah, and you know, I hate them for them to be rude to me, but I don't want them to say, I'm not going to help you. And I've been in that position. I've been on the volunteer side of this where this one unit was always, that girl was always rude to us. That she always acted like we had to do this stuff for her. So when you heard it come out on the radio that she was calling for, some assistance, oh, I'm really busy. I'm not going to be able to run over there. Nobody would go because she was so mean. So when you really need some help, you want these people to be your friends. When I was working in Orange Beach, we had a police officer that we worked with a lot, and he was just always so nice. And one night he was shot by, he pulled somebody over and he was shot. Well, he was so grateful that he knew all the crews, and he knew he was going to get good care because he always treated us respectfully. Honestly, you would never let anybody die, but I can't say it won't cross your mind from time to time. I know a few people that I know, it would be really hard to, but I would do it. But you don't want them to have to make that decision. You see where I'm going here? Okay, when you are communicating, you're also getting information about your patient. It may be bystanders. It may be the home health aide that's on scene. It could be just about anybody, so you need to get information. I always like to get the information from the volunteers on scene. If you're following them in, they've already done assessment. They know that patient. They know the family. They know the environment. They know stuff about that patient that, oh my gosh, I know I don't want to know. But they can give you insight about the patient you would probably not be able to get. So always be respectful there. As far as the vital signs, I'm always going to get my own baseline vital signs, but I also want to know what theirs are. It's nice to look at those and see how close they are. Okay. Therapeutic communication. Therapeutic communication, that sounds like therapy, doesn't it? Now, when I communicate with you as a class, I speak to you differently than I would if we were just sitting in the office, doing girl talk or guy talk or whatever we do. So we're going to communicate differently. I lead you down a path differently because I want you to learn. Same thing with therapeutic communication. If you want to elicit information from your patient, you have to do that in a certain way. If you walk right up to them and say, "What's wrong with you?" I didn't mean to spit on you. How's she going to feel? What's she going to say? First thing she's going to do is back up, and she's going to be afraid to tell me anything, isn't she? But if I come in and I'm very careful and don't spit on her, I'll go, "Can you tell me what's going on with you today?" Look her in the eye, get down on her level, act like I'm really concerned and I really care. She's going to open up to me and tell me what's going on? You bet. So this is therapeutic communication. So you want to elicit the best you can from the people around you, and the way you speak to them, the way you interact with them is extremely important. Communication techniques. Always make eye contact with your patient. If you walk in and you're spending all the time looking at all their stuff in the house, what are they thinking?
You don't care.
Yeah, that, and as soon as I leave here, they're going to come back and break in. No, not really. They probably won't think that. But yeah, you're obviously not listening. You're more concerned with the environment than you are with them. So you need to make eye contact with them. Now, I'm not talking about a stare down, but make eye contact so that they're comfortable, that you're showing respect and interest without being weird. Body position and body language is important. As you saw when I was just hanging over Ashley like this, that's intimidating, isn't it? Yeah. And if you got I told you about my partner Tilly, He's this huge guy. I mean, he would scare you to death. So he always had to be very careful about his body position that he didn't scare people. He wasn't real good at it. But if you've got your hands on your hips, that's intimidating. So kind of keep an open stance. Don't, like, you see how they're kind of kneeling down next to her? If somebody's sitting on the sofa, I'll say, "Do you mind if I sit here by you?" Sure. Then you can sit there and you can have a conversation with them, like a family member. And you're going to get a whole lot more information. And that is what we need. It's not we're here to be friends. I'm really here to get as much information about what's wrong with you as I possibly can. But you have to trust me, and the way you're going to do that is a nice conversational tone where they trust you and they believe you. Always be, let me back up, appropriate language. Appropriate language, you're going to speak to everybody differently. You're going to meet them where they are. If you've got a 6-year-old, are you going to talk to them like you do a 30-year-old? No. Are you going to talk to somebody with no medical background the same way you would be talking to a registered nurse who was one of your patients? No. So you're going to have all levels of people and all ages of people. You're going to have people that speak different languages. You're going to have people with different ethnic backgrounds, where they don't want you to touch them. They don't want to shake hands with you. So you need to be familiar with, all the different aspects of communication. Make sure that, make sure your patient understands you. Now sometimes, for whatever reason, a medic, EMT, you may feel like, I want you to understand that I really know my stuff. So you're going to use big words. If you came in there and asked some little old lady if she's been diaphoretic, she's going to, are you communicating?
No.
Are you going to get the information you need from her with that language? Absolutely not. So you're going to ask her something differently. If you go in and you ask the patient, are you a diabetic? If they don't know what that is, say, well,
Sugar.
have you been told you have problems with your sugar? Oh, yeah, that one I know. So make sure you speak with them and meet them on their level so that they can understand. Always be honest with your patient. Don't ever lie to them. All it takes is once. They see through you. They don't trust you anymore. Once they don't trust you, what are they not going to do?
Call you back?
Well, they always call you back for some reason. No, but that's good. If it's a doctor's office, you certainly don't go back. But they're not going to tell you anything. If you haven't developed this relationship, they're not going to tell you the meds they take. They're not going to tell you how they've been feeling, how long it's been going on. They're not going to tell you that stuff. But I'll tell you who they will tell. They're going to tell that nurse at the ER. You roll in, and all of a sudden, they're like Chatty Cathy, telling all these things about what's going on with them, and you're going, they didn't tell me that. They never told me that. If they didn't tell you that, it's because you didn't let them. You put up this barrier by your attitude or by your communication style. So you have to communicate with everybody like you would want to be communicated with, like a family member, if you like your family. I mentioned be respectful when you're using the patient's name. Try to call them by their name, not just, hey, you. If it's Mrs. Jane Brown, just say Mrs. Brown until she says, call me Jane. If everybody in the house is calling her Nana, that doesn't mean you call her Nana. You call her Mrs. Smith until she says, honey, just call me Nana. Everybody else does. That's all I answer to. Then I'm going to call you Nana. But be respectful. Now, this last thing is probably the most difficult thing you're going to learn to do. I know you're going to do that. Listen. We don't listen. And it's not just in EMS. It's everywhere. We're so busy thinking about what we're going to say next or what you might answer to my question. I'm not really focusing on what you're saying. So I like to have that little book out, the one I was telling you about, my little notebook. And when you're telling me stuff, I'm writing it down. Or at least I'm acting like I'm writing it down. At least then they think that you're interested, you're taking notes. But there's nothing more aggravating for you to have to re-ask a question that you just asked. They told you, but you weren't listening. I listen to talk radio sometimes. I listen to Dave Ramsey in the afternoons. But some of you might be familiar with him. But anyway, you can hear him on the radio. These people, he's asking questions, but he asks the same questions all the time. So he'll ask a question, they'll answer it, and then 30 seconds later, he'll basically ask the same question again. I'm going, Dave, you weren't listening. They already told you that. But probably once or twice a day, I'll catch him doing that, and I know he's not listening. Well, your patients know when you're not listening because you ask the same question, and they have to tell it to you again. So write it down if you're not going to remember it. But that's one thing that just really gripes me. My mom said, you got 2 ears and 1 mouth, you should listen twice as much as you talk. And the newer you are in the business, the more you need to listen and not talk. But even then, once you've been doing it for a while, you will find that you talk about 10% of the time and you listen 90% of the time. Unless you're teaching, you never finish talking. Okay, special considerations. Now sometimes you may have patients with some kind of disability, and you're going to have to work around that because you still need the same information, right? If you have a patient that has visual problems where they have to have glasses, if they can't see what's going on, you can usually tell because they act like they can't see. Can I get your glasses for you? Sure, let's go get them. Or if you have a patient that, say, can't hear, how can you get around that? I don't do sign language. You don't want me signing. I'll say something ugly. Yeah, you can write it down. I've done that several times with patients. We just write it back and forth. And then we got it, and then it's documented, and then I just keep that for my report. Mentally disabled or handicapped patients, sometimes you may have to get information from the caregiver, but always be patient and try to get the information that you need without being disrespectful or impatient. Language barriers, if you don't speak the patient's language, how are you going to do an assessment, right? So what are you going to do?
Find a translator, see if someone there
Find a
can speak it.
translator. Where can you find a translator?
A lot of time the people around them, like in Latino communities, there's normally like 50
Yep.
people there and maybe 2 of them speak English.
Yeah, oftentimes a family member or extended family, you may have somebody that can interpret. Now be kind of careful about using children to interpret, because usually they're in the school so they've learned the language, and the parents haven't. But do you really want to be talking to an 8 or 10-year-old about?
Scare the kid to death.
Yeah, you know, some of that stuff doesn't need to go through a child. So you may find another adult in the community that can do that. Oftentimes hospitals have people that work there that have the predominant languages in the area. You know, if you have a large Asian population, then you may have several people at the local hospital that speak some of those dialects. If worse comes to worse, AT&T keeps translators. You can call them, say, I'm an EMT, I'm on scene with a patient, and honestly, I can't understand them. I think they're speaking whatever. And they'll get somebody on the line. My next door neighbor used to take those calls. It was kind of funny. She got paid very well for it. Pediatric patients, you're going to speak to them differently than you would an adult. You definitely want to get down on their level. You don't want to start touching them until they're comfortable with you. You know, start at the bottom and kind of work your way up. You know, all of a sudden, go looking in their eyes or something. You'll scare them. But always with kids, be very truthful. You can make the experience, the assessment fun for them, but be very truthful with them. Don't ever offer them an option that you can't follow through with. Well, I think I told you. If you say, all right, if you don't let me listen to your lungs, I'm going to leave, guess what?
Bye.
See ya.
I don't want
Yeah.
you here anyway.
Yeah, go ahead and mention that. Okay, the pre-hospital care report. This is stuff you've already gotten. Around here, I think everybody uses computer, don't they? Does anybody know? I think most everybody's on computer. But if your computer fails, it ran out of power, you may have to handwrite those. So it's important that your handwriting is legible. That means clear enough that we can read it. But most of the time we're going to have something, some electronic device that we can use. When we document a call, we're documenting everything. If you were en route to a call and you got held up by the train down here on, what street is that in Opelika? Can't get through because of the train, so you have a delay of 10 minutes. You want to document, we had a delay at such and such intersection because of a train. If you get delayed because it's snowing and an inch of ice on the road, we had a delayed response due to inclement weather, ice on the road or whatever it is. So you want to make sure you document.
Would you want to put the time with that too, like at 10:45 or whatever?
Well, the only reason I probably wouldn't do that is it wouldn't be official time.
Okay.
Now, if you're documenting this on your PCR, you probably called into dispatch and you said, hey, this is Unit 378. We are held up by a train at such and such. And they will timestamp that. And you may or may not call them back and say, we're now en route. Usually you will, we're now en route. But if it's a weather delay, you may say, we're only going 10 miles an hour. That's the only safe, the safe speed we can go at. So they'll have that documented. So I do like to call in so it's recorded, because patients always think you took way too much time getting there. They think you stopped and, had a couple of beers before you rolled on over. So you want to make sure that, you document everything that happened from start to finish and everything in between. You're going to document the results of your assessment. You're going to document what you think's wrong with them. Then you'll document what you did for them. You're going to document what you did with their stuff. If you gathered up all of their medications and took them in a bag and you don't mention that in your PCR, they may come back and say, hey, Miss Curry took my big old bag of drugs and I never saw it again. She must have taken them home. And there are narcotics, controlled substances, all this stuff in there. Never saw it again. Who do you think's going to get blamed for that?
You.
It ain't the people at the hospital. It's you. And I've seen it plenty of times. So make sure you document. We transported a patient with a bag full of their medications. The medications were left at bedside with Nurse Nancy or whatever. Or the bag of medications was given to the patient's husband. Yeah, that works. Or spouse or whatever. So say who you gave them to, was it at bedside or whatever, or patient gave us a bag of medications, we wrote them down, we'd left the medications at the patient's residence. Or their purse, patient had their purse, the purse was left with the patient at bedside. Sometimes you may have their driver's license or their insurance card because you're taking all that information. Patient's driver's license and insurance card was left with the patient at bedside. If they can't find those things because somebody at the hospital lost it, who's going to get blamed? You are. No.
Unless
You will get blamed. I can guarantee it. Unless you can show, no, I left that with Nurse Nancy at bedside, or I left that with the patient. That word, what you write in there, they take that as gospel truth. So make sure it's always true. So make sure that when you're writing your narrative that you're painting a picture. And that's a phrase that we use, and you'll use it throughout probably any documentation that you'll ever do. We're painting a picture so that somebody can read that and they can visualize what transpired. If you respond to a rollover crash, you want to spend, a sentence or two describing what that car looked like. Because why is that important, what that car looked like?
That can give the mechanism of injury.
Mechanism of injury. If you treat for a mechanism of injury, but you don't detail what that mechanism was, they don't know if you did a good job or not. So you want to describe that mechanism. Patient fell, 5 stories. Patient fell off the ladder, 15-foot ladder from the top of the ladder. So you want to make sure you paint a picture so that whoever's reading that didn't see it can visualize and understand what all happened. And know that that is part of their permanent record. And even though you don't go to court frequently, I can tell you it's never quick. You're never going to go to court within a year of an accident or a patient that you treated. But, if you do this long enough, you're going to go a few times. And you're going to be glad. You're going to thank me that I told you that you had to write all this stuff down, because you're sitting on the witness stand, they're asking you questions. I've got it written right here. I said that I did a full assessment. I found this, and this, and the patient said he was fine, and he refused transport, blah, 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 blah. Okay, so it is a legal document. It can be subpoenaed. When they subpoena you, you have the right to get a copy of that documentation, because you're not going to remember it, most likely, so you can read over that. But if you've documented well, it can help you win a case for the patient. More times than not, you're going to be testifying either for and against a patient, either, on one side or the other of that. Most of the time, it's not against us, but it could be. So it may be what keeps you from losing a negligence case. So if you always think of it as worst case scenario, you should document well. At the top of the PCR, there's an administrative section where you're going to put all the patient demographics. Demographics is stuff like address, phone number, age, sex, all that kind of stuff. That's demographics. You can collect insurance information because our agency has to bill. You can get their billing address. So all of that stuff is going to be collected on the patient for identification purposes, but also so that your service can bill and whoever else can bill that needs to. We also use PCRs for research and for educational reasons. If your medical director pulls all the cardiac calls for a whole month and they find that Haley hasn't been given aspirin to all of her patients, he's going to want to know why. That's going to be educational. He's going to call her in and say, I noticed that on 5 of your 6 chest pain calls you didn't give any aspirin to your patients. And she says, well, they all said they had an allergy to aspirin and they had bleeding ulcers. Then he's going to say what?
Oh, okay.
He might say that. He's probably going to say, why didn't you document that? Unable to give patient aspirin because they had bleeding ulcers. If you deviate from what you're supposed to do, you better document why you did that. So we also collect statistics. You know, if all of a sudden we had a spike in calls for flu-like symptoms, then CDC is going to eventually get involved. But we're going to use that for stats, continuing education, and then of course tracking personal experience. Like I just mentioned, you know, if he sees that you've not been doing something, then they're going to call you on the carpet for that. Or oftentimes they use it to tell you you've done a great job. You know, you documented this so well, I want to show everybody else in the service what you've done. Quality improvement, this is just so we can make our delivery, our service delivery better. If we see that something's not going right, then we'll make some changes based on what is going well. All right. Run data. Your run data is going to be your times. It's going to be your chief complaint. It's going to be what your unit number is. Basically, that's all your numbers kind of thing. So that's important. They're going to track all of your times. You're going to get a dispatch time, when you were dispatched, when you went en route, when you got on scene. Some services even want to know when you got to the patient's bedside. I work down in the Orange Beach area, and so we might go on scene in the parking lot of, you know, some 30-story condo building, but we're not at the patient side for, you know, 5 or 6 more minutes. So they wanted to know when you actually made patient contact. So some may require that. You're going to put your certification level. That's important. Because when they're reading through there and they say, "Guy, you didn't give them any morphine." Well, it's because I'm EMT. We don't give any morphine. And then the official times, it's going to, when you go en route back to the hospital, that's an official time. When you arrive at the hospital, that's an official time. And then when you're totally complete with the call, you say you're in service. So that's your turnaround time. So all those are legal times that have to be attached to your run. I said that. You're going to write your PCR pretty much going down your checkoff sheet. You're not going to say, "I put on my gloves," or anything like that. Now, you may want to document if you had a gown up because the patient was squirting blood all over. But you're going to, you know, go down your initial assessment. All that's going to be on there. If you got to do a detailed physical exam or focused physical exam, you're going to document that on there. You're going to describe what you did. You're going to give the history of present illness, past medical history. All that will be in there. And I think Henry talked to you about using the chart method.
Yeah.
Chart is a very important way, and that's what I use. I start with my chief complaint. I put the history of present illness. Also under the H, I'll put his past pertinent history. You know, that's where I'm not going to put if they had appendicitis, you know, if we're there for I have a headache. But I will put you're there for a headache and he's had, you know, several mini strokes before that, then that's important. So you're going to pretty much do your initial assessment, and then you're also going to give the results of what you've seen. You know, if you're palpated and the patient said it was painful when you palpated the right femur area, then you're going to note that the patient said that was painful at that area. So you're going to note the results of your full exam. You're going to note any treatment that you gave, and then you're going to note the responses to the treatment. If you gave the patient nitroglycerin, 1 tablet, and he said his pain level dropped from 8 out of 10 to 4 out of 10, then you're going to document pre-nitro administration, patient states pain was, you know, 8 out of 10. After 1 nitroglycerin tablet, patient says pain levels down 4 out of 10. So, and then your transport information. Also in T for transport information, this usually is going to tell if you turn over patient care to the helicopter, or if you were a volunteer service, you turn over patient care to, you know, the ambulance service. Also in transport information, you want to put if you went lights and sirens, or if you just went with traffic, and every agency has different terms for that. Also in transport information, that's where I put what I did with the patient's goodies. You know, I think I told you I had a patient one time, he says, "I've got $6,000 in his pocket." I'm like, you know, so as soon as we got to the hospital, we made sure we called security and they locked that up somewhere. So I documented that. Patient told me en route that he had $6,000 in cash in his pocket. I wrote that. As soon as we arrived at the ER, we called security. That money was secured in a safe. by security guard John Smith or whatever. This is where you're going to say the patient's pocketbook, handbag, whatever you call it, purse, was left with the patient at bedside or was given to the patient's spouse or whatever it was. Here's where you'll document that you left the patient's dentures on the bedside table. You didn't transport them. This is where you say the medications were left with the emergency room nurse, Susie or whatever. Did you have a question?
Yeah, say that for some reason or another, you have your patient already in the back of your ambulance, and they tell you, oh, by the way, I have my pistol in my right front pocket. Is this where you document, okay, I asked John Smith if he could please hand me his pistol that he stated was in his right front pocket, I then turned it over to.
Yeah.
Okay.
That would probably scare me. I haven't had that. They probably just haven't told me. Yeah, that would scare me. That's somebody I'm definitely not going to aggravate
Oh, yeah.
in any way. Okay. Also under transport, if you got held up by a train or weather or something delayed your transport, you want to document it here under transport information. Your narrative. Now, we've talked around this, I think, the difference between objective and subjective. The difference in signs and symptoms. Objective is a sign. Subjective is a symptom, basically. So you're going to document those separately. I always like to document my objective information, like when I'm doing my patient assessment, doing that thing, then I'll put my objective information, and then I'll put patient says. You know, the results of my exam, patient was tender on the left, right, lower quadrant of the abdomen. I noted bruising, you know, patient, blah, 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 whatever. And then I'll say, patient stated that he, and then I'll quote, you know, he fell and landed on a log, or patient states that it's really painful there. You know, I can't independently verify that, but I'm going to put what I found and what I can document, and then I'm going to put whatever they said about it. So objective information, that stuff you can verify. Vital signs, you can verify. Pupils, you can verify that. If you've got broken bones, they're sticking out, I can verify that. Then subjective is what the patient tells you. I got a headache, my stomach hurts, whatever. So all that stuff is subject to interpretation. But I like to put quotes on that. If the patient tells me something, I'm going to quote. Patient says, quote, I only had 2 beers. They were, 48 ounces, but I only had 2 beers. Chief complaint, that's what the patient tells you is wrong. So you're going to slide that in. And then make sure you document any pertinent negatives. Patient denied shortness of breath. Patient denied chest pain. If they've got shortness of breath, I'm going to ask them, do you have any chest pain associated with that? And they'll say yes or no. So you want to document that. The narrative is going to also follow along just like your radio. Always, document stuff that you know. Don't put a bunch of opinions in there. Don't use a lot of abbreviations. I should tell this on myself because it embarrassed me. So I'm lecturing cardiology in the morning, so I was reading up on the chapter that the students have, because we're using a brand new book and I hadn't read that yet. And I was reading it, and it said, based on such and such and such, because of the patient's said capital C, capital O, this often leads to such and such. And I'm looking at that, and what am I seeing? I'm seeing carbon monoxide. CO means carbon monoxide. If the patient is retaining, or if the patient has, low level of carbon monoxide, I'm going, what? This doesn't make any sense to me. And I read throughout the whole paragraph, and they used it several times, and I'm going, it just said CO. To me, that's carbon monoxide.
Yeah.
So I thought, okay. So I went around and talked to one of the nursing professors who teaches pharmacology, and I'm thinking, I know that I ain't got any kind of carbon monoxide when I exhale, but I thought, maybe there's something nobody told me. So I'm going there and I asked her, I said, Jan, look at this. Just read this. And she read it, and she didn't say carbon monoxide. I said, read that again. And she goes, oh, the patient's cardiac output. So that simple abbreviation, because we talk about cardiac output, but we don't ever abbreviate it. So CO didn't say cardiac output to me. That said carbon monoxide. So that's how easy it is for abbreviations to be misinterpreted. If I put CP, which CP would be something that we might use, What would we be meaning if we put CP? Chest pain, probably CP, most likely. But somebody else might think that's cerebral palsy. You know, if you put that in your documentation, patient had CP. Well, what did they have? It could be any different, you know, any number of things. So make sure that you're very clear in any abbreviations that you use. That if you use an abbreviation, it's something that's used commonly within your service and commonly throughout EMS, or something that could be found in a dictionary or in a medical textbook somewhere. So don't just make up your own abbreviations. I told you about that guy down in Florida, didn't I? Did I tell you guys? A paramedic in Pinellas County, Florida. Did I tell you guys that song? Yeah.
Oh, yeah.
Yeah. Okay. That's if I can remember. Yeah, a paramedic down in Florida, Pinellas County, treated a patient, and his run report looked like this. Let me see if I can remember. He wrote, "Don't tell this, okay? That's his run report on this patient. The patient died. The family sued based on this, and they won $6 million from Pinellas County, Florida. That's the Tampa area. What does this mean?
83-year-old male.
Y'all don't give it away. Yeah, we got an 83-year-old male,
Shortness of breath.
short of breath. Of course, to a novice, that doesn't say short of breath, does it? We know what that means, fixing to die. Here in the South, we say fixing to die. Is that a polite, respectful way to refer to a patient? No. You know what this is? Nobody there knew what that was either. 83-year-old male, short of breath, fixing to die, not in the back of my ambulance, and he was done. Now, they said that they felt like the paramedic provided good care. I mean, the guy was fixing to die. He wasn't able to save him, but this is crap. So be careful about what you say.
That is so
What was he
horrible.
thinking?
What were they
Obviously, he
thinking?
wasn't, right?
That's pretty bad. The bottom line here is your PCR is a reflection of your care. That documentation, that narrative was a reflection of the care he gave, and it cost the county $6 million. So yeah, use appropriate medical terminology. Don't do that kind of stuff. You might think it, but don't ever say it and don't ever write it. Another thing, if it happened, record it. Don't leave anything out. If you make a mistake in patient care, and I've done that before, you've got to document what you did because it may impact the patient down the road. So you got to make sure you document. If you gave the wrong drug, you gave the wrong dose, whatever it was, you need to document that. They're really good about not coming after you for a mistake if you own up to it. And you guys, if any of you read the paper, you follow political stuff, if you own up to it, you're not in nearly as much trouble as if you try to cover it up. Ask Governor Christie. He's finding out. Y'all don't read the papers. Surprise. Okay. Other documentation issues. Your patient is entitled to your confidentiality. You cannot repeat what you saw in their house, what they said, what you think happened. You cannot repeat that to anybody. Now, you can use that as part of an educational tool if you're working with somebody and you want to explain to them, why this happened. Or you go back to the station and you talk in general terms about, I had a patient, they presented like this, but it turned out it wasn't that, it was this. So you can use it as an educational tool, but you want to be very careful about using any identifying descriptions. If you say, yeah, it was an older woman that lived at, 3678 wherever. In a small town, everybody knows who lives there. Everybody knows that little old lady. And you've just described her, so you can be held liable for that. You can't leave your PCRs laying around. You can't leave a half-written document on your computer and leave it open at the station. Most stations don't lock up. Anybody can walk in there and read that. So you would be charged with a HIPAA violation there, and those penalties can be quite severe. Okay, documentation when you take a refusal. This is the area with the highest liability for EMS. If a patient refuses, you have all those hoops you have to jump through. Remember we talked about them earlier? You got to make sure you tell them what you think's wrong. You've got to tell them what you're going to do for them. You've got to tell them how it's going to help them. You got to tell them worst case scenario. If they refuse, this could kill you. You need to think of everything you possibly can to convince the patient to receive care. This includes calling the ER, talking to the doctor, calling a family member, whatever it takes, and then you have to document what you did. You have to do an assessment on a patient, unless they absolutely refuse, and then you want to write that down. When preparing to do a assessment on the patient refused and would not allow me to get vital signs. They would not answer any of my questions, blah, 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 to document why you didn't complete your assessment. But even if a patient says they're going to refuse, say, well, would you mind if I just got some vital signs and just did a quick assessment, for my paperwork? Yeah, that's fine. Then you do your assessment. Now you've got some ammunition to use with your patient. I took your blood pressure, and your blood pressure is 220 over 100. People have strokes with a blood pressure like that. So you want to do an assessment, you want to document it to cover yourself on a refusal. Who's the best person to sign your refusal form? To witness it? Family member. Yeah. Don't falsify that documentation. If you've done a lousy job, you've just done a lousy job. It's better than making up something that didn't happen. I worked with a guy that he always said he got an IV on the first stick. Really? You're superhuman. And finally, the medical director caught it. I thought it was kind of weird. But I didn't read his documentation very often, but I remember a couple times where he said he got the IV and he didn't get an IV. Finally, the medical director caught it because he was always getting it. So he finally started following up behind him and asking, at the ER, did this patient come in with the IV? Because they have to document if the IV was gotten in the field or if it was gotten in the hospital. And he was lying about that. When he lost his job, they pulled his license. What did he gain?
Nothing.
Who cares? I don't get an IV on every stick, first stick, so you just tell the truth. If you make a mistake, if you're writing it out, you just cross through it and you write it above it. You don't rub it out, with your elbow and make it big nasty. You don't do it like that. You just strike it through and write above it. If you remember something later, then you write an addendum to it. If you forgot to document something, you can go back and add to that. Just say the reason. Say, I forgot to add this when I was doing my report earlier, or we were very rushed, I had back-to-back calls, and I forgot this until I looked back on my documentation, and I needed to add that the patient also complained of blah, 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 blah. So you can make an addendum, but you want to get it in there as soon as possible. All right, you respond to a call for an unconscious male. Upon arrival, the patient is awake, alert, and he's walking away. He says he was just sleeping, he doesn't need or want any treatment or transport. Okay, so we're talking about a refusal, aren't we?
Mm-hmm.
Is this a patient?
Yes.
Did he call you? Did he say he called?
No.
Did somebody else called? Okay, is this a patient? Who thinks this is a patient?
Yeah.
It's okay. Don't be scared. I'm not taking names. You said it was a patient. Raise your hand, girl. All right, who thinks this is not a patient? Anybody? So half of you raised your hand. You thought it was a patient. The other half of you are deceased. What? Your arm's broken. You can't raise your hand. Okay, who thinks this is a patient? Dylan? Jeremy? You guys? All right, who thinks it's not a patient? If you didn't, you got to raise your hand either before or after. Yes or no? What's that, Dylan? It's not a patient? Is that what you're saying?
Yeah.
You're not thinking anything in the world. You just can't. You're just not going to move your hand. You're going to burn too many calories that way. Is a complete assessment and physical exam needed on this guy?
Yeah, probably.
If you can get it.
I was just sleeping. I don't need you. I don't want you. Get out of my face. I got things to do. And he walks off.
He's the patient, but he's not going to let you do it.
How are you going to document this call?
Patient was breathing, obviously was in good condition of health.
Because he was breathing and talking. Refused care, asked us to leave.
Yeah, with this patient, he probably is not a patient. Somebody else
And,
called.
you know,
Somebody
refuse.
saw him laying down, and they called 911. You get there, and he said, "I was asleep. Didn't call you. Don't want you. Get out of my face." Just say, "We were called for one unconscious. We arrived. The patient said he didn't call. Nothing was wrong with him, and he just walked off into the sunset." In that case, that's what you document. Was unable to get any patient information, including name. That's really a no call. If somebody else called and that person there says, "I don't need anything, everything looks okay," in most cases, you ask the patient, "Would you mind if I do a quick assessment?" If they say no, they've said no. You've done your job, you document. Ask the patient, he refused, wouldn't sign this, wouldn't sign that, but your service should detail for you what constitutes a no call. So for some of these, they may not even have you fill out a patient care report. Where I worked, everywhere that I worked, they required, if you were dispatched there, they need some kind of documentation, even if
Even
there
if
was
there's no services
nobody
needed.
found. Yeah, no
Yeah.
services needed,
No
patient,
pay.
you know, it was not the caller, whatever. Now, sometimes there are special situations like a mass casualty where you can't document all the important information on a patient because you got 30 patients and you've only got 15 minutes. So we have these neat little tags that we'll use for MCI. And with these, you do a quick assessment of your patient and you'll determine really what their level is. If they're dead, they're going to get the red tag. If, do what? Oh, I'm pointing right at it. Black tag, sorry. They're black tag, it's not a good thing. But you tear these off, so if the patient's just minor, you just leave everything here. You know, I broke my finger, then you're gonna get this whole thing, and it's gonna be the lowest one is what your patient is. So if they have, say, a broken leg, can't move real well, but they can be delayed, then they're gonna be a yellow. If they have any respiratory issues or altered mental status, then they're gonna be a red, and then if they're deceased, you know, then they're deceased. So you'll tear those off, or whatever the last one is what the patient is. You may or may not get information written here. If you're doing initial triage, you might just tear these off and you just leave this with the patient. And then the people that come behind you may fill some of that in, and that will go to the hospital with them. It's called a triage tag. We'll talk about triage at length at the end of the semester. Now, there are other special reporting situations, a dog bite. Remember we talked about dog bites? That's a special reporting thing. Who do you have to report that to?
Animal control.
Yeah, animal control, whoever, you know, if there's some authority you have to report that to. If there's, I'm sorry?
You also have to report it to your,
Supervisor.
the
To
guy
what?
at the
Your,
hospital.
your supervisor.
The medical control, the physician
The,
at the hospital,
yeah, the one that,
infection control. Yeah, for something like this, I'd probably tell those guys you're probably gonna have to get shots. Not good. If you have, do what? Yeah, if it's like an exposure, that would be your designated officer. Yeah, that would be, you know, if you got a needle stick, then you report that to them.
it wouldn't be dog bite either?
Yeah, I'd tell them at the hospital, they're going to recognize your dog bite when you're getting treated. Then they have to report that to, I think law enforcement gets that, and then they disperse that to whoever they need. If you're ever injured on the job, you're going to have to fill out a special injury report because your employer is responsible for any injuries that you get on the job. If you don't report it, you're not going to be able to recover for that. So you have to report. In most places, you got to report within 24 hours, but as soon after the incident as possible. If you ever have any kind of hazardous material exposure or a needle stick, that has to be reported. Anytime you are a party to or you recognize or suspect abuse, that has to be reported. So there are a lot of situations where you're going to have to report stuff. So we got here. Radio report. You know what goes in your radio report, don't you? See, I always think I do such a good job here. I hardly have to review this stuff. ETA, what's that? Estimated time of arrival. You call the ER. You want them to know how far out you are. What all about your patient, the chief complaint, pertinent history of present illness, not everything you've learned. You should be able to make a radio report to the hospital in under about 45 seconds. You just get there, give them the meat of it, and move on. They always are going to want to know the mental status, vital signs only if they're not normal, what you've done, how the patient's responded.
So would you say pertinent vital signs?
when I'm calling in. No, if it's pertinent,
Yeah.
I'll give it.
Yeah.
If it's not pertinent, I'll just say they're within normal limits. Yeah. Got to have all your patient's information. Nature of call, that's always going to put you're usually going to have to put your dispatch. You were dispatched to shortness of breath. Upon arrival, patient was unconscious or whatever. Location where the patient was found. You know, a lot of people don't document that, but you should put it if you're in the patient's home, the side of the road, in a park, an office building. All that's pertinent for a lot of different reasons. So make sure you put where they were found. And if it's something that their position is important, you want to make sure you document their position. You also want to document if there was any treatment given before you arrived. Like I always like to document who did spinal mobilization on the patient. If the fire department on scene did the spinal mobilization, I don't want to take credit for that. So I will say spinal mobilization was provided by fire department on scene, or the splinting was provided by fire department on scene, or whatever that was. So I don't want to take credit for things they've done, and they don't take credit for things I do. PCR is a legal document. Make sure, we use it for a lot of different reasons. Make sure that your report paints a picture. So when you read it back, you should always read back your report. Write it down and then go back a little while later and reread it. It's kind of like letters and emails that you send. Yeah, you should always reread those because we say some pretty squirrely things sometimes. We leave out words. I got a text today and the guy said that I couldn't something. And I said, did you mean I could or I couldn't? He goes, oh, I meant to say that you could, not that you couldn't. So make sure you paint a picture and you get it accurate. In your radio report, pertinent facts. Don't give them a bunch of crap. They don't have time to listen to it, and they're going to start tuning you out. Just when you tell them something important, they've tuned you out. You don't want to do that. It's kind of like what you do to your patients. The report at bedside should be a more complete report. Make sure you document who you gave that report to, who you turned over care to. Always put that in your patient care reports. If you find that the volunteer fire department or the nurse at the ER or somebody is getting real stinky with you and rude and irritable with you, try to look at yourself and see if you're doing some bad communication skills, Okay, organize your material. When you're writing your patient care report, organize that. But when you're calling in the hospital, you need to have a routine of what you say. Because you got a patient here, who knows what's going on with them. You're nervous, you're calling somebody you've never talked to before. I can guarantee you the first 100 times you make that call to the hospital to give a patient care report, you're going to be scared witless. You're just nervous about doing that. If you've got a format that you always go through, you always say the same things. We're en route with a 57-year-old female, chief complaint, chest pain. All right, I've already done the first 4 or 5 things right there. Next, maybe I'm going to give pertinent past medical history of present illness. Then I'm going to give my vital signs or whatever. Just kind of keep it in order. In fact, if I remember to give it to you, I've got a form that you can carry until you get comfortable, where when you're getting information from your patient, you just jot that down. And when you call in, you just practically read it off. It makes it real easy.
We get a copy of that?
Yeah, I'll bring it. Let's see. Yeah, this is just an example of, oh no, I'm not going to make you do this. I might send you this as a homework assignment. Take all this information and organize it like you would do in a radio report. I'll type that up and send it to you. And then just have you do that. Okay, what's today? Tuesday? What are we doing Thursday?
Chapter
28 and 29? So we're going to start trauma. That bleeding and shock we did last night was the first chapter of trauma. You got to read that. And then Thursday we're going to do 28 and 29. Ethan, don't leave yet. Y'all sit back down. So, we're here till 9 o'clock. Where y'all running out to? Is it snowing or something outside? Heck no. Not yet. We're starting trauma. A lot of trauma is self-explanatory. That's why I'm okay with going ahead and starting these chapters, but just test you on 10 through 17. So over the weekend, make sure you study 10 through 17 well. This will be your second sectional test. If you did poorly on the first one, this is an opportunity for you to make up for lost time. So make sure you study that.
Isn't this the third one?
Is it a third? Okay, third one. You still have opportunity because I think we have 7 tests, and hopefully we're going to be here on Thursday. But I will see you Thursday. If we're not meeting, watch just like we did last time. And if you've got clinical schedule, make sure you check with Brandy because nothing should be official until you've completed your drug screen. And those were just done Thursday. So make sure you check with her before you run off to a clinical, okay? All right, I will see you guys. Be safe if it's snowing tomorrow.